Hello and welcome back. Today we'll be discussing imaging in the diagnosis of acute pancreatitis. There will be part 2.1 in an approach to vomiting and abdominal pain. Um, so I'll be considering this as a sequel to the discussion on acute pancreatitis, its causes, mechanisms, and evaluation. So we'll be reviewing the cross-section anatomy of the upper abdomen in particular with a particular emphasis on the pancreas. We'll understand the various phases of a contrast-enhanced CT abdomen as they pertain to the pancreatic parenchyma. Uh, we'll understand the imaging characteristics that define or indicate the presence of acute pancreatitis. We'll formally define what the terms acute pancreatitis, collection, and necrosis mean radiologically. We'll review the scoring systems that have been developed to quantify radiologically evident acute pancreatitis. This will include the original CT severity index as well as the modified CT severity index. We'll formally define what peripancreatic necrosis means. We'll try to understand the role of imaging in the diagnosis of 5 specific complications of acute pancreatitis, and then we'll try to deduce why and then by extension when CT imaging is indicated in a case of suspected acute pancreatitis. Finally, we'll put everything together and we'll talk about how clinical versus radiological parameters are important in the prognostication of patients with acute pancreatitis. So as you can see, we've got a lot to cover. So getting right into it, this is the cross section of the upper abdomen. Now, in this cross section, you can obviously identify the liver. Obviously, this is the anterior aspect of the patient. This is the posterior aspect of the patient, and by convention, our images are always viewed such that the right, as if you're looking at the patient from the foot end of the patient. So this is the right of the patient, and this is the left of the patient. Okay. Now, okay, that's the liver. This is the liver, and this is the stomach. This is the spleen. This is the lesser sac. So as you can see, uh, the lesser sac is behind the stomach and it communicates with the greater sac via this space. This is the epiploic foramen. I've highlighted the greater sac, and the greater sac is then, these are both spaces that are part of the peritoneal cavity proper. Then the thing is, in radiology, we see, especially CT imaging and MR imaging, we see everything in black and white. So I've shaded everything in black and white. So as you can see, once it's shaded black and white, it becomes quite less apparent. It's not as easy or as evident. Now, this is the actual image that we see on a CT scan. So as you can see, it's quite evident what all the further other findings. So this is the liver, this is the stomach, this here is the spleen, this is the left kidney, that is the pancreas. What I've highlighted in blue is the inferior vena cava. What I've highlighted in red is the abdominal aorta. So I hope that much is clear. Now moving on, this is a cross section of the abdomen at a slightly lower section. You can still see the liver, but it's been separated into two segments, two lobes. Then we've got the kidney on both sides. Then we have the pancreatic uncinate process and head and the tail of the pancreas. And you can see that the tail of the pancreas actually partially goes into the lienorenal ligament. So this ligament ligament is just basically a duplication of the peritoneal membranes. So this contains part of the tail of the pancreas extending into the lienorenal ligament. Then we have the spleen. These loops represent the loops of the small intestine, because this is the upper and left side of the patient. These would likely be jejunal loops. Loops on this side of the abdomen at lower sections would be ileal loops. Then this is the greater omentum. As you can see, the greater omentum is essentially hanging like a apron in front of the abdominal organs, excluding the liver. And then on either side, we've got the two ascending and descending limbs of the colon. and this is what you would see in a CT schematically, and then I can replace that with the actual CT image. So now in this actual CT image, you find the liver there on the left side, liver on the left side. This is actually the gallbladder. Okay, it's distended. In my diagram, it was not distended. These are the jejunal loops, uh, as I discussed in the left upper part of the abdomen. Then we've got the left kidney. We've got the colon. The ascending colon is not clearly visible here. This is the pancreas. So as you can see, the pancreas has become much smaller, and a part of it extends into the tail, and you can't see that in the section here. Uh, Importantly, this is the uncinate process of the pancreas, and it lies in between the aorta, that is the red structure here, and this, the red structure just anterior to it. So these two structures represent the superior mesenteric vein and the superior mesenteric artery. This will be the artery. Okay, so this will be the vein, the superior mesenteric vein, and this will be the superior mesenteric artery. Okay, you can actually see branching from the superior mesenteric artery going into this fatty structure here. This structure is basically the mesentery of the jejunal loops. So these are all jejunal loops. These are all jejunal loops, and this is the mesentery of the jejunal loop with the blood vessels running through them. And this would be the second part of the duodenum, and this is the third part of the duodenum. And then, as you can see, just at a higher level, there would have been a transition from the duodenum into the jejunum. Okay, so I hope that anatomical orientation is clear now. Now, moving ahead. Okay, so that's the first and the third parts of the duodenum. Okay. Now, anteriorly, you can see this green structure here. That is the greater omentum. Now, the greater omentum covers the other organs as we just discussed, except for the liver. Now, once we've gotten our bearings as far as the anatomy is concerned, we need to understand what phases the CT imaging of the pancreas of the abdomen in relation to the pancreas is divided into. So we use, ideally we should have three phases. We give IV contrast and we give positive oral contrast. I'm not a radiologist, so I'm not going to go into the details of when it is given, what is the cutoff. As a clinician, as a internal medicine doctor, I usually get the reports, and the fine tuning of the process done by the radiologists. I'm not really involved in that, so I'm not going to go into it now. But importantly, whenever you are evaluating a CT image, at least two phases have to be imaged, and the phases are named as follows. We have the arterial phase, we have the portal venous phase, and we have the venous phase. So this is basically on where the contrast is located within the various blood vessels that you can see in the CT scan. So in the arterial phase, you only have contrast in the arteries, and it is at this time that the pancreas briskly and diffusely enhances, and the enhancement is homogeneous throughout the entire pancreas. Now, after that, you have something called the portal venous phase, where you have contrast within the portal veins, but you don't have contrast within the hepatic veins or the IVC. So, in that situation, also the pancreas continues to show diffuse, brisk, homogeneous enhancement. So, as you can see, the pancreas is enhancing both in the arterial and the portal venous phase. Then we have the venous phase. Now, here we have contrast both in the portal vein and the hepatic veins and the IVC. So, at this time, the contrast is washes out from the pancreas, and the attenuation of the pancreas goes back to its baseline value that you would see in a non-contrast CT scan. Okay, so these three stages are important to define so that we are clear about what we're talking about subsequently. Now, coming to acute pancreatitis proper. Now, when it comes to acute pancreatitis, we first need to identify and define what exactly is acute pancreatitis. So, what are we looking for? There are some terms. I'll define those terms, and then I'll talk about the clinical caveats that relate to those terms. So, acute pancreatitis itself is just essentially defined as radiologically defined as. Now, we've already talked about the clinical definitions. That was the the specific type of pain that occurs in acute pancreatitis and the elevation of serum lipase more than serum amylase. Okay, or amylase and or lipase, but lipase being more specific, more than 3 times upper normal limit. Okay, so in addition to that, the third criteria was the imaging findings. So the imaging findings that qualify qualify something as acute pancreatitis include: one, glandular enlargement. This could be diffuse or focal, and this could be and the presence of pancreatic fat stranding, and we'll just see what that means. And the presence of collections and or necrosis nearby may or may not be there. That doesn't really matter. The first two things really have to be there. Now, this has been actually formalized in the Balthazar and Ranson CT severity score, and we'll talk about that. Now, a collection is defined as an accumulation of fluid within the gland and or around the gland. Okay, and collections as they get older and depending on their contents are divided into 4 categories, and we'll talk about that subsequently. Now, fluid here just implies that there is decreased attenuation due to increased water content. So, in on CT, the lowest attenuation is that of air, which would be around minus 1000 Hounsfield units. Now, after that, we've got fat. Okay, then we have water that is almost near zero, slightly more than zero. Actually, 0 to 70 around that range. And then we have the other structures that we see, the other tissues that we see. So the more the water content of a tissue or more the fat of content of a tissue, the blacker it will look on CT. So a fluid basically is defined as collection is defined as a fluid accumulation within the gland or around the gland, and that fluid is then has to have a attenuation somewhat that of water. Now, necrosis is defined as it can be pancreatic necrosis, that is necrosis within the pancreas, and it can be peripancreatic necrosis. Now, pancreatic necrosis is essentially decreased, usually completely absent enhancement of the gland. This is during the arterial phase particularly, but usually we see portal venous phase, so arterial and or portal venous phase. Okay, but by definition it is the arterial phase. And pancreatic necrosis is defined as a peripancreatic fluid collection that is either not homogeneous, that is, it is not having just fluid density, or it has a density other than that of fluid, and or we have a pancreatic fluid collection that is actually extending into the pancreas, so it is not maintaining the anatomical boundaries of the pancreas. So these are the two things that are defined as peripancreatic necrosis, and we'll see this how what that looks like on imaging just subsequently. Now, the other findings that could be present are liquefaction of tissue and hemorrhage, but these need not be present. If they are present, they strongly indicate the presence of hemorrhage, of necrosis. Now, first we'll talk about what qualifies as acute pancreatitis. So clearly, we're going to talk about gland enlargement and peripancreatic fat stranding right now. So this is what the schematic that I just discussed was. Now, in this, it is quite clearly seen that once I replace it, uh, okay, so we've got a normal pancreas here. Now, the pancreas is very readily visualized on a CT cross section because right behind the pancreas we have this white structure. That is because this is the superior, what is that called? The splenic vein. So the splenic vein, highlights the pancreas. As you can see in a normal pancreas, this is the arterial phase. So the splenic vein is obviously a branch of the tributary of the portal vein. So these the portal vein and its tributaries as well as the arteries are have contrast in them. So this is a portal venous phase. Now in the portal venous phase with positive contrast within the stomach, what you find is that the gland is enhancing equally. So the enhancement is there throughout the head of the pancreas, that is in the head, the neck, the body, and the tail of the pancreas, and it is equal everywhere. It is homogeneous. Now, on to the right, what you see is that there is very minimal absolutely no enlargement of the gland. That is, the gland is similarly sized, but importantly, there is some kind of abnormal tissue around the gland. Okay, so this is basically what is called stranding. So stranding is essentially these wispy, whitish structures that are found when fluid, insinuates in between the septa that are present in the fat that are surrounding these abdominal organs. Okay, so that is called stranding. Now, on the second case, we can see again this is a lower the pancreas at a lower section. Now this is the head of the pancreas, this is the uncinate process, and this is a part of the body and the tail of the pancreas. Now here this is completely normal, but here you see that the uncinate process and the head are highly enlarged in size. Okay, there is some stranding there. These are these structures on the side. There is some stranding, but the enlargement of the head is the more prominent finding. So uh, normal size per gland with stranding is acute pancreatitis, and an enlarged gland with or without stranding is acute pancreatitis. So either of those two qualify this as acute pancreatitis. Now, when do we say that the gland is enlarged? For us to say that the gland is enlarged, there are certain cutoffs that have been defined. So that means that the maximum width of the gland at the head, body, and tail has been defined. So if it is thicker than 30 or 3 centimeters at the head, 2.5 centimeters at the body, or 2 centimeters at the tail, it is said to be thicker than normal. So it is said to be enlarged. Okay. Now the normal length of the pancreas is 15 to 20 centimeters. The increase in length of the pancreas is not very easily discernible, so it's not something that we normally say. Okay. Now, okay. So as we can see, I've highlighted the abnormal tissues. Now the next thing that we'll talk about is we'll talk about what a collection is. So, like I said, a collection is a fluid accumulation around the pancreas or in the pancreas. So, here you can see near the tail of the pancreas in the splenic hilum extending into the splenorenal ligament, we have an interesting uh, collection. It is homogeneous, it is fluid density, and it is at the tail of the pancreas. Now, the attenuation is the same as that of water, therefore, it is water, that is fluid. Now, importantly, you can see along with this, the rest of the pancreas is enhancing completely normally, and the splenic vein that is visualized in this section at least appears to be normal. Okay. Now, contrast that to the pancreas here. The pancreas is parts of the pancreas are enhancing, so you can see that parts of the pancreas are enhancing. Okay, and however, there is this fluid that is there around the pancreas, and this fluid around the pancreas is notable for being slightly inhomogeneous. So you can see in this fluid collection, the attenuation varies at different locations within the fluid collection, and however, still the enhancement of the pancreas, the normal pancreas within the collection is normal. Okay, so as you can see here, parts of the fluid collection are darker than expected, and if you can see, not very sure if it's clear, here in this particular area, the collection is slightly more dense than would be expected. So the collection's attenuation is not that of fluid, therefore the collection represents either bleeding or necrosis within the collection. Okay. Now, the rest of the findings have been systematized as part of the CT severity index, and the successor to that, that is the modified CT severity index. So we'll talk about these two, and we'll try to, you make the assessment of acute pancreatitis on radiology very uniform. So the CT severity index is also called the Balthazar and Ranson CT severity index, named after the people who described it initially. And then there's obviously the successor, that this is a modified CT severity index. Now we'll compare the two first. So now in terms of collections in the original CT severity index were graded from A to E, whereas the modified GT severity index only talks about gland enlargement and peripancreatic stranding. That is the basic definition, radiological definition of acute pancreatitis, and that is given the same score. We'll talk about the scoring just subsequently. Then we have necrosis. Now, CT severity, the original CT severity score used to give necrosis scores of 0, 2, and 4 based on what percentage of the gland appeared to not be enhancing, that is, appeared to be necrosed. Whereas the modified CT severity index has a dichotomous say classification, that is score of 0 if less than 30% of the gland is necrosed, and 2 if more than 30% is encrosed. Now, complications, as defined radiologically, were not included in the original CT severity index, whereas 5 distinct complications have been included in the modified CT severity. Now, the CT severity index, both of them predict morbidity much better than they predict mortality. But both criteria, both have been compared in multiple studies, and most have given a slight edge to the modified CT severity index because it includes these complications. But there are studies that also favor that the use of the original CTSI over the modified CT severity index, and that is the reference for one of these meta-analyses that you can have a look at. About the Balthazar and Ranson criteria for severity of pancreatic collection. What I've done is I'm going to describe the original CT severity index on the on the left of your screen, and the modified CT severity index on the right. So let's see how that pans out. Now, the original CT severity index gave a score as well as a grade, whereas the modified CT severity index only gave a score. And so a score of 0 or a grade A in the original CT severity index gets a score of 0 on the modified CT severity index, and that essentially represents a normal gland. Now, a score of 1 or a grade of B, B would stand for big gland, that is a diffuse or focal enlargement of the gland. Now, a score of 2 is C. C is that the contour of the gland has changed, so there is contoured fat rather. So that was what I refer to as fat, which is more commonly referred to as fat stranding. Now, with pancreatic gland abnormalities, concomitant peripancreatic inflammation essentially just means fat stranding. Now, importantly, in the modified CT severity index, both the enlargement of the gland as well as the contour, the fat stranding around the gland are given a score of 2. Okay, whereas in the original CT severity index, they were given separate scores of 1 and 2. And then they were additionally, just to create a little bit of confusion, given grades of B and C respectively. But it's easy to remember once you know the grades. Now, a score of 3 or a grade D was a D for discrete, that is a single fluid collection anywhere, that is within the gland, outside the gland, doesn't matter. Okay. Uh, Now that is given a score of 4 in the modified CT severity index, and in the original CT severity index, a score of 4 or a grade E was either of the two, that is either presence of multiple or at least more than one fluid collection, or the presence of air. Okay, so it is either of the two. Now, as you can see in the present modified CT severity index, it is both are given a score of 4. So just to reiterate, a normal gland is given a score of 0, a big gland, that is an enlarged gland or fat stranding, is given a score of 2, and any number of fluid connections or air within the gland is given a score of 4. So it's scored from 0 to 4, whereas the original series giving was scored from 0 to 4, but a grade was also given, and 1 and 2 were separate, and 3 and 4 were separate. Okay. Now, like I mentioned here, in the modified CT severity index, unlike the original CT severity index, the other findings that were given that are given value is the presence of certain complications that are discernible on imaging. So those complications are as follows. So these are the extra pancreatic complications, with a caveat, that is those that are diagnosed on imaging. So I use a mnemonic A, B, C, D for that. So A stands for ascites, B stands for blood vessels, that is vascular complications. C stands for conduit, that is GI tract complications. D stands for damaged parenchyma. We'll see what that exactly means exactly. And E stands for effusion, that is pleural effusions, and ascites. But ascites is already covered. Okay. So now importantly, in the modified CT severity index, air is not given a score. So that we'll see is one other caveat that is there regarding the modified CT severity index. Now, in the Balthazar and Ranson criteria, the of a severity of pancreatic necrosis or pancreatic inflammation, initially we talked about just pancreatic inflammation. Now we're going to talk about necrosis. So basically, pancreatic necrosis is defined as a lack of pancreatic enhancement involving whatever percentage of the gland. So in comparing the two, the original CT severity index, if the less than 30% of the gland showed lack of enhancement, then the score that was given was 2. In the modified also it is 2. Now, in the original CT severity index, if 30 to 50% of the gland was not showing enhancement, then a score of 4 was given. Whereas in the modified version, regardless of whether it is more than 30 or more than 50, the score is always 4. Now, in the original one, if it was more than 50, a score of 6 was given. Okay. So as you can see, essentially in the modified CT severity index, this has been replaced by the presence of extrapancreatic complications that are discernible on CT imaging. The total score is graded similarly in both CTSI and a modified CTSI. So a total score, that is a combination of the inflammation score as well as the necrosis score. If it is less than 4, it is considered mild. If it is 4 to 6, it is considered moderate. And if it is more than 6 to 10, it is considered severe. Okay. Now, importantly, you have to understand that the original CT severity index, that is the Balthazar and Ranson score, makes no mention of the very important finding of peripancreatic necrosis. So let's see what this essentially means. So what is peripancreatic necrosis? So you can see in this particular section what is visible is this entire structure. So let's get our anatomical bearings clear. So this is obviously the spleen. This is obviously the liver. That is very clear. This is the vertebra at the back. So that will be the vertebra. Okay, just anterior to the vertebra, we have our aorta. Okay, I'll use red for that. So the aorta is giving off a artery anteriorly. Okay, uh, this is probably the superior mesenteric artery. Now, uh, importantly, as you can see, there is something within this collection here that is actually the normal pancreas, and it appears to be enhancing reasonably normally. But around it, what we find is there is a fluid collection. Now, unlike the fluid collection that I had described earlier, this collection is a little bit different. How is it different? In different parts of the collection, the attenuation is slightly different. Okay. So as you can see, if the area that I've highlighted, that area has got a slightly different attenuation or is slightly brighter than the rest of the collection. Uh, Whereas the area here is also slightly brighter in part. So we would say that there is a inhomogeneous attenuation for this collection. So the peripancreatic fluid is not homogeneous and has a non-fluid attenuation in some portions. Thus, the fluid appears to extend into the pancreatic body. Additionally, it appears to extend into the pancreatic tail at this area. So these two things constitute what we call peripancreatic necrosis. Now, coming to the complications of acute pancreatitis. So see, these are the complications where imaging plays a major role in establishment of diagnosis. Obviously, in the previous video on the topic, I have already discussed the clinical complications that are diagnosed, clinically and based on laboratory parameters. But these are the 5 complications that are seen primarily on imaging. So these have been defined as extra pancreatic complications. As I've just discussed, it is A for ascites, B for blood vessels, that is vascular complications, C for conduit, that is GI complications, D for damaged parenchyma, and tell you what that means, and E for effusion. Now I'll just shade out ascites and effusion, and we'll get to the next point. So A is ascites. Ascites we'll be discussing as a separate topic, so I'm not going to go into the imaging of ascites. Essentially, it's just fluid accumulation within the peritoneal cavity. Now, here what you can see is I have essentially highlighted the thrombus within the splenic vein. Okay, so this is the pancreas. The entire pancreas appears to be enhancing homogeneously. Uh, this is the splenic vein at the back, and in the this is obviously the portal venous phase, that is why the splenic vein is so prominent, is enhancing, and within that, within the lumen, we have a thrombus. I have shaded it as blue. Now, okay, Now, at the bottom, we have what are called the early and late arterial phase. So, initially, when I discussed the different phases of the pancreatic CT, I only talked about an arterial phase. Okay, but in actuality, there are two subdivisions to the early and late arterial phase. So, the late arterial phase is around 35 seconds after injection of contrast. So, in the early arterial phase would be prior to that. Now, what you see in this image is actually this within this collection there is a very odd shaped, very bright, uh, you know, almost very bright, almost for the balloon-like projection. Now, importantly, as you go from the early arterial phase to the late arterial phase, the shape of the collection remains the same, but the attenuation is slightly lesser. So this is a little bit more gray. This is a little bit more white. Okay. Now, if you take your attention and compare the attenuation of the aorta here to this collection, it's almost exactly the same. Similarly, in the later image, the aorta and this collection, or sorry, rather the aorta and its this collection's attenuation remain the same. So that means this is essentially part of the vasculature of the patient. So this is what we call an aneurysm. Okay, but it could also be that there is actually this aneurysm could be bleeding, or there could be some damage to the wall and there could be blood coming out. So how do I know that this thing that is coming out from that appears to be coming out from the vessel there is not actually blood coming out and is just actually the blood within the vessel, but the vessel is dilated, that is there is an aneurysm. So this is a splenic artery aneurysm, but like I said, there is a slight caveat there. So let's see how do you differentiate between the two. So see, it could be an aneurysm. It could also be a bleed coming out from an aneurysm or from a damaged vessel in general. So how would one differentiate the two? Uh, Basically, what we do is we have to look at the images serially during three phases. That is the non-contrast phase, the early arterial phase, and the late arterial phase. So, in terms of in case of an aneurysm, as you can imagine, when there is no contrast, the aneurysm is not going to be visible because the contrast only highlights the vessel, and otherwise the aneurysm is obviously not going to enhance since it's part of the blood vessel. During the early arterial phase, there will be identical attenuation as compared to the aorta, and the shape will be essentially the same of that of the aneurysm. So it will be ovoid in shape. Now, later in the late arterial phase, the shape will remain the same. The shape will not change. Okay, but the attenuation is exactly the same as that of the aorta because the aorta also contains arterial blood and the aneurysm also contains arterial blood. So the attenuation remains the same and remains the same as that of the aorta, and the shape remains the same during both the early arterial and late arterial phase because the wall of the aneurysm prevents blood from going in different directions. However, when it comes to a bleed, what we find is that essentially initially most bleeds are not visible, or they may be visible and have the attenuation of clotted blood. So as we've discussed previously, that is around 50 to 70 also Hounsfield units, but they can be very difficult to see. Now, during the early arterial phase, what you will find is that blood is seeping out of the blood vessel, so it is coming out. But see, it is getting mixed with the contents of the soft tissue or the collection that the bleeding is occurring into. So because of that, its attenuation is slightly lower than that in the aorta. So the attenuation, because of mixing, is slightly lower than that in the aorta. Then finally, during the late arterial phase, the attenuation remains essentially the same because it's blood mixing with with fluid, but because there is nothing to contain that blood within that space, during the late arterial phase the blood will expand. So the density actually expands with as you go into the late arterial phase and it changes shape in some way. It could go from being ovoid to slightly more wide. It could go from being straight to slightly longer. So there is a change in shape. What type of change varies, but there is a change in shape. So let's see what that looks like on CT. Now, just for the sake of clarity, this is actually a pigtail catheter that has been placed inside the collection in order to drain it. So we'll ignore it for now. So as we've discussed, this is an aneurysm because in the early arterial phase and going into the late arterial phase, the shape does not change and the intensity of the blood within the aneurysm is the same as that of the aorta. Okay, so here it is slightly less intense, but the aorta is also becoming less intense as contrast is leaving the aorta and the arterial bloodstream. So this is ovoid and isodense to aorta. This is also ovoid and maintains the same shape, and again is isogenic to the aorta. So our inference is that this represents an aneurysm. Whereas later on in the next image, what you can find is there is a somewhat of a streaking there. Okay, so there is a streaky hypoattenuation if you can look carefully. Now the attenuation is significantly less as compared to the aorta. The aorta is bright white, whereas the attenuating structure, the streak here is actually is only slightly more white than the grayish fluid around it. Okay. Now in the next image, what you find is that actually the attenuation is again slightly lower than the aorta, and if you look carefully, the shape here has changed. Okay, so this was the original shape, and now the shape is much larger. Okay, so the shape of the this thing has changed, and that indicates that the blood is not contained within within a walled structure. So there is a change in the shape, and this continues to be hypoattenuating compared to the aorta. So that therefore it is an active bleed and will therefore require embolization. Otherwise, the patient may become hemodynamically unstable. Next, coming to the third complication, that is your conduit, that is GI wall complications. So they are very simple to see. Essentially, what you can see is this structure anteriorly. This is your transverse colon, and these are some of the jejunal loops that are there. And as you can see, these are the blood vessels within the mesentery of the jejunum that are going towards the jejunal loops. Now, if you look carefully, there is a slight thickening of the wall here, a significant thickening of the transverse colon wall here. So that thickening is what we call a GI complication. Now we'll be discussing for GI wall thickening and what that implies in the next video after our discussion on acute mesenteric ischemia and evaluation of causes of bowel obstruction. Uh, so at that point we'll be deriving it in detail. So I'm going to leave it at that for now. Okay. Now. So that will be approach to, that is the next discussion, approach to vomiting and abdominal pain, part 2.3. Okay. Now, what exactly does damaged parenchyma, the fourth complication, mean? This includes one, collections. Now, collections could be pseudocysts or walled up necrosis, and we'll just get to what that means. It could be air in the gland, that is in the gland or in fluid collections around the gland. First, we'll talk about collections. So, collections have been, formalized. Their nomenclature has been formalized. What is called the revised Atlanta classification. The revised Atlanta classification contains two things. It divides them based on the duration of symptoms as less than 4 weeks or more than equal to 4 weeks, and based on the presence or absence of necrosis. And now we've already understood that pancreatic necrosis implies lack of attenuation, and peripancreatic necrosis means that the fluid that is present around the pancreas has got a inhomogeneous attenuation at different parts, and or the fluid is extending into the pancreatic parenchyma. Okay, because obviously the pancreatic parenchyma, if it is not necrosed, is going to be it is going to remain intact and fluid will not be able to seep into it. So if you have no necrosis and the collection has been there for less than 4 weeks, and this is clinically determined from the onset of onset of abdominal pain, not joint pain. So then then the collection is called an acute peripancreatic fluid collection. Now, if it has lasted for more than or equal to 4 weeks, then it is termed a pseudocyst and usually develops a wall. Similarly, if necrosis is present, if there is necrosis, then collection that has been there less than 4 weeks is called an acute necrotic collection, and a collection that has been there for more than or equal to 4 weeks is called a walled off necrosis. So these are the nomenclatures for these things, and we'll see why that is important for prognosis. Now, again, damaged parenchyma could also mean air within the gland or in fluid collections around the gland. So what does that include? Air in the gland could theoretically be the result of what all? It could be a result of infection, that is a gas forming organism, and this is the most common cause. It could be due to fistulization with a gas containing structure, that could be any part of the GI tract. It could also be due to introduction of gas into the collection from outside the patient. Okay, that is, we put in a catheter or something to drain the collection, that is introduced this thing. So obviously these are two very specific clinical scenarios, and in this case we'll be able to find a fistula between the collection and the GI tract, and in this case we'll have a history of placement of a catheter. But in any other situation, gas within the gland or around the gland, in a collection with around the gland, indicates that there is an infection, and that worsens prognosis. Okay, so gas, however, uh, Now, it indicates infection, but it has a low sensitivity. So it is only present around 20 to 25% of pancreatic infections or complications. So most infections don't have gas-producing organisms, and therefore get undercalled if you just depend on imaging. So the clinical parameters of the patient have to be taken into account as well. No. So provided there is no fistulization with the GI tract and there is no external drain in place that has been placed, gas around the pancreas is equal to infection. And this is important because mortality rates depend on the infection in cases of, in any case of pancreatitis that is quote unquote non-mild. So what does this mean? So we divide the severity of pancreatitis based on its severity into three categories. We've got mild pancreatitis, which has got an overall mortality of less than 1%. We have moderately severe pancreatitis, which has a mortality rate that is slightly higher, that is less than 5%. And we have severe pancreatitis, which has a mortality rate of 15 to 25%. So as you can see, mild pancreatitis usually will not get affected and usually will have an infection, the overall mortality rate that is less than 1%. So very, very rare. Okay, whereas moderately severe and severe pancreatitis, the mortality rates actually are dependent very heavily on the presence or absence of an infection. So if an infection is not present, in both moderately severe and severe pancreatitis, the mortality rates are less than 5%. Whereas if an infection is present, the mortality rates increase to almost one fourth, that is 15 to 25%. So it is the presence or absence of an infection that determines the overall mortality rates in cases of non-mild, that is all that is moderately severe to severe pancreatitis, and therefore the presence of air in imaging is a highly specific finding that needs special consideration. So this raises a natural question that uh, when should one imagine patient in case of acute pancreatitis? So we've understood what is pancreatitis on imaging. We've understood what are the what a collection is, what necrosis is, and understood the five clearly defined, radiologically defined complications that you are visible on CT. So with imaging, we can only find these things and we can only define these things. At different points in the clinical course of a patient with acute pancreatitis, all of these questions may become relevant. So it is at that point that the help of CT is to be taken. CT should not be done in every single case of pancreatitis, at least in the beginning. Okay, so say we have a hypothetical case where there is an onset of abdominal pain. Now, after onset of abdominal pain, 72 hours, the first 72 hours pass by, and then we have got 72 hours, more than 72 hours to less than 4 weeks, and always obviously more than 4 weeks. So obviously this cutoff is to determine, whether it is walled up necrosis versus acute necrotizing pancreatitis, like, like I discussed earlier. So in the first 72 hours, the thing is that if we image unnecessarily, we are not going to be able to talk about the complications. We're not going to be able to get an idea about how much peripancreatic collection or necrosis has occurred. So at this point, usually pancreatic imaging is not indicated. The only real indication would be if you don't have a patient with the typical abdominal pain of pancreatitis and or there is no significant elevation in serum lipase and or amylase. So in this situation, only if the diagnosis is doubtful, we do an imaging. Otherwise, do not image acute pancreatitis in the first 3 days of presentation. Now, beyond this, between 72 hours and less than 4 weeks, we can call complications. Okay, we can quantitate the amount of necrosis and we can use the imaging findings to give a patient an idea about the morbidity that they are likely to experience from pancreatitis. So the CT is almost always required to quantify necrosis and to assess for complications accurately. Now, after 4 weeks, it is only indicated in very specific scenarios. That is only if a complication is suspected. So there has to be the clinical suspicion of a complication. Okay, there is persistent abdominal pain or worsening abdominal. The patient is going into sepsis, so you're suspecting a pancreatic infection or a peripancreatic infection. The patient has suddenly gone into shock. Okay, so you're suspecting either septic shock or you're suspecting loss of blood into due to an aneurysm or due to an aneurysm. So they suspect an active bleed. So as we've seen, those are the complications that are visible on CT, and that is when we do a CT in these specific scenarios. Otherwise, a CT is only indicated in this space of time. Okay. So, now what about a repeat CT? So, repeat CTs are done in case you have a suspected infection, that is, we have recurrence or worsening of abdominal pain, and or the patient has clinical features of sepsis. Second, the other situation in which they are done is when we are suspecting a vascular complication like a splenic veins or thrombosis, which could, present as upper quadrant pain or upper GI bleed, because obviously the left gastric veins are tributaries of the splenic vein, and if there is a acute thrombus that causes an increase in pressure can cause bleeding. We also do it when we suspect active bleeding, that is, there is a rapid fall in HB or there is unexplained shock. Okay. So finally, let's try to finalize what is the CT good at doing in acute pancreatitis and what it is not that good at doing. Okay, so CT is actually not very good at predicting mortality. It is much better at predicting morbidity. So what actually is good at predicting mortality? It is actually the clinical scores. So that is based on these scores that we divide the pancreatitis in pancreatic cases into mild, moderately severe, and severe. So there are two classically described scores, the BISAP score and the Ranson score. So BISAP is an acronym for B for blood urea nitrogen, that the cutoff is more than 25 milligram per deciliter. I stands for impaired mental status, that means AMS, altered mental status. S stands for the presence of SIRS, and this is the same classical definition of SIRS that is used generally. A stands for age more than 60 years. P stands for pleural effusion. So these are the five parameters that are taken into account in case of biceps. Now, Ranson score is done at two is measured. There are 11 parameters, but they are not assessed at the same time. They are assessed at admission and then after 48 hours or within 48 hours of admission. So let's see what sense we can make out of this. So the parameters are also divided into two separate categories. That is, there is gallstone or biliary pancreatitis, and then there is every other form of pancreatitis. Obviously, most commonly alcohol-related pancreatitis. Similarly, after 48 hours, also the biliary and other causes are given slightly different scores. So it's a little complicated to remember, but if you divide it based on understand it logically, that is based on what the parameters are trying to tell you about. So the parameters can tell you about your the okay, so the pre-morbid performance status of the patient, that is how healthy the patient was before the onset of pancreatitis, the presence of systemic inflammatory response syndrome, the presence of homeostatic compromise, that is any type of no abnormal physiology. So this particularly after 48 hours we start thinking about third space volume loss, that is third spacing of fluid into the peritoneal cavity, the pleural cavity, or you're into a fluid collection somewhere around the pancreas or within the pancreas. Now, importantly, in the BISAP score, this only includes a pleural effusion, whereas in the Ranson score, this can include multiple different types of effusions. So we'll talk about that just now. Now, in case of at admission, what we look at is one is age, we look at the TLC, and we look at the lab parameters. Now, when I say lab parameters, what I mean is the L stands for LDH, A stands for AST, and B stands for blood sugar, that is random blood sugar. The cutoffs are different in case of biliary and in case of other pancreatitis. Now, in case of after 48 hours, what we look at is one, very importantly, we look at the serum calcium values. This is an important question that is routinely asked. We look at how much the hematocrit is increasing post 48 hours, because more third space fluid loss is there, the more the hemoconcentration will occur, and therefore more the hematocrit will change. We look for evidence of fluid sequestration. Now, this is usually done using a chest X-ray or USG abdomen. As I said, you should not, or in to quantify imaging severity, we should not do CT within the first 72 hours. It should only be done for confirmation of diagnosis. So obviously, Ranson score is only being done when you have know that the patient has acute pancreatitis. So this is should be done using a chest X-ray, AP and lateral, along with your USG abdomen. Now, then we have the anion gap, and this is the blood serum anion gap. And then we have the change in blood urea nitrogen. So this is change in hematocrit and change in blood urea nitrogen, whereas in biceps there was an absolute value that was given to the blood urine nitrogen. So as you can see, the main parameter that affects pre-morbid performance status is the age of the patient. SIRS, the parameter that is taken in Ranson's, is TLC, the total leukocyte count. Other parameters are not included. In case of homeostatic compromise at admission, lab parameters, that is LDH, AST, ALT, and just the AST, not ALT. The AST and the blood sugar level values are important. Whereas later on, after 48 hours, the parameters that are important are serum calcium, and this is something that is routinely missed by people because the necrosis will result in release of anions which chelate calcium and cause a reduction in serum calcium level, so hypocalcemia, as we've discussed in our talk on the clinical presentations and complications in the previous talk. Then we have an elevation in hematocrit, fluid sequestration on imaging other than for CT, anion gap, and delta urea nitrogen values. So the cutoffs are as such. So it is 70 years for, I'm not going to read out all of them, but the cutoff values are important. As you can see, they are different depending on whether it is biliary or it is the other. You can take a screenshot and go through them yourself. Similarly, the cutoff values for serum calcium obviously remain the same because serum calcium is the same for everybody, and hematocrit change also remain the same. The cutoff, this is an important value to remember, that is a rise in hematocrit by more than 10% and a fall in serum calcium by more than 8. Okay, so it's a little easy to remember because the fluid sequestration is 4, 6, 8, 10. Okay, it goes like that. Anion gap values also differ between the two. So it is 5 here at 4 here. And blood urine nitrogen values significantly differ between the two. That is in case of this is the only parameter that is higher in phase of non biliary pancreatitis. That is more than elevation more than 5 milligram per deciliter. So it is 5 into 5 was 25. So it is 5 there. Okay, for biliary it is 2 only. And okay. So based on this, you calculate a total score. There are 11 parameters here, 11. So you get out of which only 5 are measured initially, and the remaining 4 are quantitated later. Whereas in biceps, 5 are quantitated initially, and the remaining 6 out of 11 are quantitated later. Okay, and finally we've got your the bicep score, and based on this we can classify pancreatitis into mild, moderate, and severe. The parameters included in the two scoring systems are important. In addition to this, there is also something called the Apache 2 score that is used, and that has been validated in pancreatitis, but that is it's very complex, so I'll be discussing that later in our discussions on critical care. So in this discussion, I have discussed the cross-sectional anatomy of the upper abdomen with particular emphasis to the pancreas. We have understood the various phases of contrast enhanced CT protocol abdomen as they pertain to the pancreatic parenchyma in particular. Then we have talked about the imaging findings that indicate acute pancreatitis. We have talked about formally defined the terms acute pancreatitis collection and necrosis. Then what we've done is we have reviewed the scoring systems now that have been developed to quantify radiologically evident acute pancreatitis. So these were the CT severity index, the modified CT severity index, and we compared the two. We formally defined what peripancreatic necrosis means. As we discussed, it is inhomogeneous collection around the pancreas or extension of that collection into the body of the pancreas. Uh, then we have understood the role of imaging in the diagnosis of 5 specific complications of pancreatitis: A, B, C, and D. Okay, the A for ascites, B for blood or vascular complications, C for conduit, that is your the gastrointestinal tract complication, D for damaged parenchyma. I've defined what damage to pancreatic basically means, and E, as I discussed, was effusion, specifically pleural effusion. Okay, then we've deduced why and by extension when CT imaging is indicated in a case of acute pancreatitis. And finally, we put everything together. We've understood that clinical parameters are more important in determining the overall mortality risk. So BISAP and your Ranson score are good at predicting mortality. But an additional parameter that is required when the patient is classified as having moderately severe to severe pancreatitis is the infection. Now, infection can be obviously deduced clinically based on the presence of, worsening clinical status, sepsis, etc. But again, an imaging finding that can give you an idea is a CT but that CT has high specificity, low sensitivity. So only 20 to 25% of those CTs are going to show air within or around the gland. And in that case, you can be reasonably sure that it's an infection. But in every other case, the assessment of whether or not infection is present is clinical. Now, radiological parameters are better at predicting morbidity. That is what we use the CTSI and modified CTSI scores for. And as you can see, imaging in acute pancreatitis is aimed at diagnosing and more, prognosticating patients with acute pancreatitis. It is not primarily required for assessing the cause. Assessment of cause is something that I am usually involved with. So, assessment of cause requires you to review all the causes that we had discussed in the previous video on in this series. So, if you are not clear about that, I would urge you to go and have a look at that. So, thank you for watching, and I'll see you in the next video. Uh, Okay, so thank you for watching. And next, we are going to talk about the role of prognostication in acute pancreatitis in terms of clinical versus radiological parameters in detail. So, as I've just discussed, there are validated scores that are based on hemostatic derangement that are superior at predicting mortality as compared to imaging. So, the total score, as I just said, in case of biceps, if you notice, I have not mentioned the total score of biceps and Ranson. So, in biceps, it is 1, 2 and more than equal to 3. So if you have a bicep score of 1, that is mild pancreatitis. Okay, so now in these patients, additionally, assessment of whether or not an infection is present is not relevant. So it's not really important. Whereas in moderately severe and severe pancreatitis, the mortality will change based on the presence or absence of infection, and therefore a CT may be required. Similarly, in Ranson's, the cutoffs are less than 2, indicates a mortality, predicted mortality of around up to 3%. Uh, 3 to 5 indicates a predicted mortality of 11 to 15 percent, and more than equal to 6 predicts a predicted mortality of up to 40%. Okay, so like I said, imaging would be important, not important in case of mild. It would be important in case of moderately severe. It would be important in case of severe pancreatitis. So like I've just discussed previously, infection there becomes an extremely important parameter, because once you cross a threshold of 1 and you cross a threshold of 2 in bicep and Ranson's respectively, automatically the patient's mortality is primarily then determined on whether or not they develop a superadded infection. Okay, so that's how we use the combination of clinical parameters as well as radiology to determine the patient's prognosis. So that brings us to the end of this discussion. Thank you for watching, and I'll see you in the next video.